Hello, I'm Johnny, a fifth year medical student at the University of Edinburgh. This presentation is being delivered as part of an SSC 5B project with the university, but also a QI project in the PICU, and my supervisors for this are Umer and Andrea. This is an outline for this presentation. I'll have a quick chat through the results of the baseline questionnaire, then provide some information on delirium, and then in the latter half I'm going to introduce a screening tool for delirium and finish off with a brief talk about management. So the baseline questionnaire. We had 59 responses to the baseline questionnaire in December and January, which is great going, so thank you very much. As you might remember, the questionnaire started with 17 true-false statements about paediatric delirium, which was a knowledge test composed by Johns Hopkins University. The average score of our unit on this knowledge test was 76.5%, with a standard deviation of 13.2. The Johns Hopkins team averaged 78%, so we're not too far off their score. There were three statements that I wanted to highlight as these got the most incorrect responses. The first being, benzodiazepines can be useful in the treatment of delirium. This is false, and only 42.4% of respondents said so. Delirium usually lasts several hours. Again, this is false. It has a fluctuating course and usually lasts for several days. And finally, children generally do not remember being delirious. This again is false. The second part of the questionnaire investigated screening practices and attitudes towards paediatric delirium. 90% of respondents said that they do not screen for delirium, and the main barriers to delirium screening were lack of knowledge and confidence and no available screening tool. However, all respondents said that they were happy to learn more about paediatric delirium, and 83% of people said that they'd be happy to screen for it in the future. Finally, the mean confidence score for diagnosis and management of paediatric delirium was just a hair under 4 out of 10, with a modal score of 2 out of 10. So, overall, the baseline questionnaire showed that there are some knowledge gaps and confidence is relatively low, so there's room for improvement, but there's a willingness to address these things, and that's quite a positive position to be in. So now I'm going to talk through some of the pointers about paediatric delirium to hopefully add to people's existing knowledge. So, what is delirium and how can we define it? This is the DSM-5 diagnostic criteria for delirium, which we can use to define delirium as a syndrome of acute brain dysfunction with a fluctuating course characterised by inattention, disturbed awareness and disorganised thinking. Importantly, these changes in mental state can't be attributable to another cause, for example, hypoglycemia or drug withdrawal. Delirium can be divided into three subtypes: hyperactive, hypoactive, and mixed. This is a Venn diagram that tries to capture some of the presenting features of delirium and split them into the relevant subtypes. Delirium is very common, especially in the PICU. An international study involving 25 PICUs found that at least 25% of patients have diagnosable delirium. And as for the split between delirium subtypes, hypoactive delirium is the most common, and hyperactive delirium is the least common subtype. The pathophysiology of delirium is complex and not fully understood, but I've made this flowchart that summarises the key events in the theorised pathway. So, an at-risk individual is exposed to a trigger or insult which causes a stress response. Cytokines, chemokines and prostaglandins are produced which cause either direct neuroinflammation or indirectly cause neuroinflammation due to blood-brain barrier dysfunction. Neuroinflammation leads to imbalances between neurotransmitters, and the neurochemical disturbances lead to the cognitive disturbances. The different subtypes of delirium are likely related to which neurotransmitters are disturbed and in which direction they're disturbed. So, for example, hyperactive delirium might be associated with increased dopamine and glutamate, but reduced GABA. When considering the risk factors for delirium, we can split it into predisposing and precipitating factors. Predisposing factors being something that's pre-existing and which makes the patient more likely to develop delirium, and the precipitant being the factor that actually triggers the delirium. And this is how they link into the pathophysiology flowchart. If someone has a lot of predisposing factors, then they require less of a precipitating factor to become delirious. And I'm highlighting this because early recognition of those with lots of predisposing factors may allow for interventions to reduce triggers and prevent or minimise delirium. Lots and lots of things can contribute to delirium, And here is a list of some of the predisposing and precipitating factors. I'm going to give you a few moments to read the list, and I'd like you to think which of these could you impact with your own practice. You'll see that sedation and medications are on the list, so I'll just take a quick moment to expand on this. Rather than dwell on each medication that can contribute to delirium, I'd just like to draw your attention to benzodiazepines and opioids. If a child receives benzodiazepines, they are 5.2 times more likely to develop delirium, and that figure is after using a multivariate model to adjust for confounding variables such as severity of illness. Opioids, when used as a sedative, increase delirium risk. However, opioids are beneficial when used for analgesia alone, as pain is a risk factor for delirium. As for the other drugs, the main point to be made is that these are commonly used drugs in the PICU. Hopefully this slide about outcomes of paediatric delirium can highlight why it's a relevant condition that should be targeted in QI projects. Delirium is associated with an increased mortality with an associated odds ratio of 4.39, and that's after correcting for severity of illness on admission. Delirium is associated with an increased length of stay and prolonged time on a ventilator. A PICU stay is 85% more costly when a patient has delirium, and again that's after controlling for age, severity of illness and length of stay. Worse mental health outcomes are associated with delirium. There's diagnosable PTSD in up to 28% of PICU survivors, but 62% of PICU survivors have features of PTSD. Cognitive decline after delirium is commonly reported in adult populations, and there's emerging evidence that this is also the case for children. And then finally, the longer-term outcomes have not yet been adequately studied, so there could be more negative outcomes that we aren't even aware of yet. So thank you for your attention so far. The next things to cover are making a delirium diagnosis and the management. The gold standard for diagnosing delirium is a review by a psychiatrist, but given the high incidence of delirium, this simply isn't feasible. You may remember from the last presentation that it's documented in the literature that clinician judgment is not very sensitive, regardless of experience, and so relying on judgment alone will lead to a lot of missed diagnoses. Screening tools are the solution and can be used by members of staff for consistent and sensitive delirium diagnosis. In recent years, multiple screening tools for paediatric delirium have been developed and validated. Coming into this project, the two tools that seem to offer the most promise were the Cornell assessment for paediatric delirium and the SOS-PD. We decided that the Cornell assessment might be the most suitable for this unit because it's shorter, validated for all ages, includes children with developmental delay, and has had slightly better uptake in other units. Another bonus is that it comes with a table of developmental anchor points to help make scoring more objective. So here it is, the Cornell assessment for paediatric delirium. As you can see, it has 8 questions which are each answered using a Likert scale. You then write the corresponding number in the score column, add up the scores for each of the 8 questions to give the final total. And a total above 9, or including 9 rather, gives a positive paediatric delirium diagnosis. These 8 questions correspond to the DSM-5 criteria that we looked at before. However, patient baseline is important to consider. This is a good place to involve parents and consult the grid of developmental anchor points, which we'll look at in a couple of slides' time. But first, you'll notice at the very top there's a box for RASS score. Before screening for delirium, you need to know how deeply sedated a patient is, and we can formalise this using the Richmond Agitation Sedation Scale. This is a rather self-explanatory tool that probably all of you do informally as part of your observation of the patient, so all that's needed is to document the number. If someone has a score of -4 or -5, then you can't reliably screen for delirium because the child is too deeply sedated to show symptoms of delirium. But this does not mean that they're not delirious, because sedatives just prevent the child from being symptomatic and will hide any underlying brain dysfunction. An additional bonus of using a tool like the RASS is that it makes communication of level of sedation easier and more objective. This means that it's easier to set sedation targets and avoid over-sedation. As I mentioned before, the Cornell assessment for paediatric delirium comes with a grid of developmental anchor points. It relates different ages to each of the 8 questions on the CAPD to try and make it more objective and consistent between raters. So here's a summary flowchart for diagnosing delirium. First, after handover, consider the patient's risk factors for delirium. Then remind yourself of the Cornell assessment questions so you can observe for these things during your shift. When you're more familiar with the questions, you can easily bypass these steps. So then you observe the patient over the length of your shift. This is important because of the fluctuating nature of delirium. If required, you can refer to the table of developmental anchor points or ask family about a patient's baseline. Then towards the end of your shift, measure the RASS score, and provided that it's greater than -4, you can fill in the Cornell assessment table and add up their score. A score of 9 and above indicates delirium, and this process should be documented in the notes and mentioned during handover. To try and get this up and running, I've made some posters which will contain the Cornell assessment questions, as well as the RASS table and the grid of developmental anchor points. Hopefully in the future, we could make this a standard part of the online documentation and observation sheets. But for the time being, here are the posters. One covers key information on delirium and the other covers delirium screening using the Cornell assessment. There's also going to be an information sheet for parents that explains what delirium is and how they can be involved. I hope that the screening process is clear. It's quite a self-explanatory tool, and I'm sure that it'll become a quick and easy part of your routine after a few shifts. So now on to delirium management. The principle of delirium management is to identify and target modifiable risk factors in order to either prevent or minimise delirium. This includes optimising the PICU environment and personal care of the patient. It also includes good pain management, appropriate sedation, and by that I mean avoiding over-sedation and minimising the use of deliriogenic drugs, and finally, management of agitation. Delirium management could be compared to balancing a seesaw. On the one side, you have the things that are done in the PICU to treat critical illness but contribute to delirium, so mechanical ventilation, sedation, and invasive monitoring. And then on the other side, you have the idealistic conditions for preventing delirium, which don't at all take into account managing critical illness. Now, I'm not naive enough to preach about stopping benzodiazepine use or anything. So obviously we've got to approach delirium management with realism and turn the focus onto making smaller changes to tip things in favour of delirium without having a negative impact on the critical illness. For those who have heard of Dave Brailsford, it's the marginal gains approach. And in the next few slides, I'm going to try and highlight the things to focus on to try and achieve this. But first, we need to remind ourselves of the predisposing and precipitating factors for delirium, which we looked at earlier, and hopefully you remember which of these you think are modifiable. First, starting with environment. I've been lucky enough to spend a short amount of time looking around the unit, and I've also spoken to Andrea and Umair a lot about what goes on inside the PICU. PICU is always going to be a somewhat stressful place to be, but the unit does a great job of trying to optimise the environment for child comfort. The things on this mind map that you already do are very worthwhile maintaining. And the move to the new hospital is an opportunity to consider if there are any marginal gains to be made. So I'd encourage you to actively think about these things as you move into the new unit to set up even more good habits. Now for personal care. Again, these are things that you all already do. The ones to emphasise are early mobilisation and talking to the patient even if they seem deeply sedated. Because people with hypoactive delirium can still remember things, and you only need to watch a few videos of patient stories to hear how much comfort they find from staff talking to them. The final thing to emphasise is parental involvement. You are the best people to facilitate their involvement, so when we have the information sheets printed, feel free to give it to the parent and have a quick chat about it. Good pain management is key for preventing/reducing delirium. Brummel and Girard note in their review on delirium prevention that a lack of pain assessment is associated with increased benzodiazepine use, presumably as poor pain management leads to agitation and/or delirium, and then the benzodiazepines that are given could further contribute to delirium. Pain assessment, even in sedated patients, and appropriate titration of analgesics reduces delirium. Overuse of opioids is associated with delirium, so in complex patients you should involve the pain team. Choice of sedative is a huge topic and certainly too large and complex for this project to tackle. As mentioned before, Benzodiazepines and opioids as sedatives are a pretty deliriogenic combination. Alternatives such as alpha-2 agonists, clonidine and dexmedetomidine, are better than benzos and opioids when it comes to delirium. However, they aren't a great option, especially in patients on inotropes. So the most realistic solution is to use benzodiazepines and opioids for the shortest appropriate amount of time and to try and replace them with clonidine if the patient still needs sedation. Sedation targets and objective monitoring of sedation with a RASS score can be used to avoid oversedation. And I believe that this is done in the unit already. Not only will this help with delirium, it'll also help with drug withdrawal, something that the unit is also already good at preventing. The final part of delirium management is the management of agitation. Before giving medications, we obviously need to resolve any reversible causes of agitation, so bowels, bladder, any other discomfort, and give reassurance. But there are times where medication is needed for the safety of the patient. In adults and in some PICUs, antipsychotics are used off-license for the management of agitation and have been shown to decrease the need for benzodiazepines. Here, chlorpromazine can be given IV and enterally, and alimemazine is an antihistamine with some antipsychotic properties. Antipsychotics are not without their side effects, so they should only be used if really needed. The above points on delirium management can all be summarised into the ABCDEF bundle, which I'm sure you're all familiar with, and that brings my brief overview of delirium management to a close. The above can be summarised into the ABCDEF bundle, which I'm sure you're all familiar with, and that brings my brief overview of delirium management to a close. The summary points for this presentation are that delirium is common, we should consider risk factors for it, and screen every shift using the Cornell assessment for paediatric delirium. To manage it, we need to look for the modifiable risk factors, make the marginal gains, and then aim to optimise sedation and analgesia. If you would like to read more about paediatric delirium, here are 4 papers that I would recommend. And thank you very much for your attention.